Hello everyone and welcome to this evening's radiology webinar. My name is Jemima Mead. I'm Head of Marketing at VET.CT. Before I introduce Manuel, our fantastic speaker, I'm just going to take a couple of minutes to tell you a little bit more about VET.CT and how our services can help you, your teams and your patients. If you don't know much about us, VET.CT is a global company of over 200 specialists and we are here to help you. Whether you're in first opinion practice, university, specialist hospital, or another clinical setting. The service we're probably most well known for is our radiology service, where our team of 150 radiologists provide expert interpretations on a range of imaging modalities, from X-ray through to CT, MR, fluoroscopy, nuclear medicine, and across the full spectrum of species. What sets us apart from other providers is the quality of the reports our team provide. Not only do they annotate the images so that you see the areas of concern that our team see, we ensure the reports you receive contain clinically relevant differentials and comments, and all of our reports are backed by our unique clinical warranty. What that means is that you can trust the information in them and proceed with the next steps for your patients. Not only this, but we also have an incredible support team who are all clinically trained and available 24/7. You can ask them for help and support at any time, and you can also communicate directly with our team of radiologists if you have any questions about your case. We also have a team of specialists across 13 different disciplines who can provide clinical support and advice on your case way beyond radiology. Manuel's just moved to the next slide, which has a QR code on. So if you'd like to see the difference that VET.CT brings for itself, just scan that code and you can see some of our example reports. You can also reach out, you'll see the sales@VETCT email address. You can reach out to any of our friendly client success team to book a no obligation discovery call at any time that suits you, just to find out more. You don't have to commit to doing anything off the back of that call. Next slide, please, Manuel. Just a little bit of housekeeping for tonight's webinar. It's being recorded, so what that means is we will share the link with you. You can share it with colleagues. You can watch it back as well at a time that suits you. The talk will be about 30-35 minutes long, and then we'll go into a Q&A session. So if you have a question that comes up during the talk, if you click on the bottom, you'll see Q&A. If you enter the question in there, that will come through to me and I'll collate them and ask them to Manuel afterwards. We don't have a microphone system for you to be able to ask direct questions directly. So if you do have any questions, either through the talk or at the end, just pop them in there. So on to tonight. It's with great pleasure that I'm welcoming Manuel Pinilla, one of our senior radiologists. Not only is he an incredibly experienced radiologist, he's also our Senior Director of Teleradiology at VET.CT. And he is going to be talking tonight about the basics of CT protocol configuration. So Manuel, over to you, please.
Thank you very much, Jemima. So I'm going to start the clock now. We have about 30 minutes. I think we'll probably go over as usual. I prepare too much content and then I just try to speak fast to make sure I cover everything. So I apologize for that. We are on webinar 2 of 8. So if you are interested, you want to see the previous one, it should be available, I believe, in YouTube. The first 4 that we are doing are theory, and they will be followed by practical case-based sessions to reinforce the concepts that we view in theory, but also to introduce some new ones. We will be covering things such as the indications of CT and so on, and those will be done by some of my colleagues. This is the content of the theory part. That's a little bit what we did in webinar 1. We basically focused on to what image quality should be like on a CT. What are the characteristics of the CT image? Webinar 2, which is today, we are going to continue down the protocols, explaining what are acquisition parameters and what is processing parameters, how those are different, why you need to know the exact difference when one happens, and so on. And as part of a CT protocol, we need to be all very aware of how do we use contrast media, because it is used in lots of our studies. Now, that is going to take a whole webinar for itself, which is going to be the next one with Andrew Holloway. And the last one, so the last one I will do of the four theories, once it's going to be a little bit more actually practical. We're just going to review CT images together. I'm going to give you some tips as to how to proceed and kind of to set up some sort of paradigm that when you open a CT study, you know what you're doing and you can identify the different series, know if they are good or not, whether you should reprocess the images and so on. Now I'm going to do a quick recap, and I would love to have that button there, but it is just what it is. It's just a little image. You cannot skip the recap, sorry. So if you were here, you have to hear this twice. But I'm going to go very quickly about what makes an image good, what kind of parameters can we assess. The first one is very easy, it's very obvious, it's a spatial resolution. CT is amazing at it, and it's the ability to see small stuff, provided those structures are surrounded by something very different. For example, the pulmonary vessels are surrounded by air, we see them beautifully, or the bone, trabecular bone, the margins, joint spaces, and so on. The other concept we discussed is noise. To simplify, noise basically is not enough data on that image. It results in an image looking grainy, a little bit like this. So it does not look very smooth. It looks all edgy with lots of lines, stripes, and dots. Okay. The way to reduce it, so noise is the enemy on an image. It is always there. You just want to reduce how much there is or reduce what it looks like reduces impact. We need basically more radiation. Is when you do an image like a photograph in the dark and it looks mottled, you need a flash or the lights on or so on. But in our case for CT, it's going to be more radiation. We can increase the slice thickness, which is a little bit like taking multiple photos together and fusing them into one. We get more information. And also like what we have done actually here, these images are identical to start with, and we have done different filters. So we've done a filter that reduces the impact of noise. And the reason why noise is important is what allows us to view the soft tissues in detail. The less noise, the better contrast resolution. And when we are going to be mentioning contrast resolution, we are not really talking about contrast media yet. We are talking about the contrast within the image. Like, for example, here, the fact that we can see the blood and the myocardium has completely different densities because muscle is more dense than blood. Or, for example, the same thing with the liver versus an hepatic vein or a portal vein, or, for example, the gallbladder here. Okay. And the last one is temporal resolution. It's pretty straightforward. It's our ability to resolve things that are actually moving. Basically, is to avoid artifacts. So you can see this ghosting and doubling of the images. And when we look, for example, in a sagittal, we can see every time the dog breathes, we start to get the anatomy a bit distorted. We can miss lesions. We can have lesions that appear of different shape that they should be, and so on. So those are kind of the 4 qualities. And now we're going to go through the process of performing a CT scan, and we are going to explain how to make sure that we've got enough of all of those ingredients so that we can make a diagnosis. This is a slide I put the other day. I think it's probably one of the most important to understand is that it is not possible to fully optimize all those resolutions. If you want very high spatial resolution, you are going to end with poor soft tissue resolution. Okay, it's a little bit like you need to decide which one you want. The way to work around this is understand the specific indications. The more precise the indications are, the more you can optimize your study for that particular condition. If you are just doing a CT because, I don't know, the cat's not really eating, just do a full body, it's very difficult to optimize because you are not maybe optimizing it for, I don't know, the GI tract, the brain, the thorax, whatever it is. Also, try to limit the study to as few body areas as possible. And the main reason for that is that you cannot, if you compare a protocol for, I don't know, a head for neuro CT versus a thorax, they are radically different, the parameters. So you cannot really fully optimize both, or you may have to do it twice, but then that complicates how you do the post-contrast because you only want to give it once and so on. So trying to focus in the area of clinical interest is important. You must always finish a CT study and have at least 2 series. Even if you do not give contrast, you will always have 2 series, and I will explain why. We are going to go into detail of that. And lastly, you will start with your scanner with some protocols, and then you need to understand how to change them, how to fine-tune them, and gradually build a richer, more detailed library. And overall, be ready to compromise. Okay, everything is a compromise on CT. The more radiation you use, the better images, but then that's going to have downsides, and it is all a little bit of a compromise, really. Now, quick overview of the CT scanning process. I think if you've ever run a CT scan, you know all of this, but there may be a few little things, subtles, that you may have not the concepts clear. There are some common misconceptions. One is what we call the acquisition, and the goal of this is to irradiate a patient and retrieve some data. We call it the raw data. Now, this is going to happen obviously in your hospital. This is what is going to happen while the patient is there, before and while the radiation is happening. So while the CT scanner inside the tube inside the CT scanner is rotating and is making noise if you want. Once the radiation stops, we have that raw data that needs to be processed into visible images. And this happens within the control room. So it's the same computer that is physically attached to that scanner. There's probably one day there will be cloud solutions for this as for everything else. But for now, you are working in your control room in your hospital. And the end result of this is that we have visible images. We call them DICOM images. So it's an actual image, often it's just a JPEG or a TIFF or some sort of compressed image, which has got a lot of metadata with it, details of the study of the patient and so on. So again, this happens in your hospital, but the difference is that even if the patient is gone, you can always access the raw data and process more series. So that's why it's important to differentiate this. And lastly is viewing, which you are going to do in a computer or send them somewhere in another place for someone else to review them. Okay, so that is a little bit a completely separate process of these two things, which are generating the image and the other side, which is evaluating or reviewing those images. Now, where it gets confusing, as we are going to see, is that as you are acquiring images, there is some processing happening simultaneously, so that while the patient is going into the scanner, you are already seeing those images appear. And I think that's where there are sometimes a little bit of confusion, and hopefully by the end of today's session, you will no longer be confused. So CT protocols, where we're going to try to set today the steps to create them and to maintain them. What are they? Is obviously all of the instructions that you need in order to perform a CT scan. Now, what are they for? It's obviously the first goal is to get diagnostic images, something that allows us to make a diagnosis, and they should be specific to body areas and generally also for indications. You may have just a general thorax one or a general abdomen one, but with time, if you don't, you will see that you are going to need maybe like a shunt search for small dogs and one for large animals, or maybe you want something a lot more specific for, I don't know, urinary or whatever it is. They are also designed to ensure patient safety and minimize radiation exposure for the patient in the first place. Even though our patients do not have a lifespan as humans and therefore radiation is less of a concern, it is still a concern. It should be minimized, particularly if you work with exotics, with animals that live sometimes longer than us humans. The other one is if you overuse radiation, you overuse the equipment, it will not live long. Particularly the tube may be damaged and so on. And these are very power hungry systems as well. So it's even an environmental concern. Okay, you will know that this is not just plugged into a normal socket. They've got a specific power supply and they go through electricity like crazy. And it's not that I am forgetting radiation exposure to humans. This is as simple as that. This is categorical. No level of staff radiation exposure is acceptable. To me, it's not acceptable for radiographs either, but I know in some parts of the world it's even legal and encouraged and normal practice. In others, it's not. When it comes to CT, really, you should not be on that room while the scanner is running. Okay, you really have to be outside, so there's no patient holding. Even if anesthesia, anesthetist has to go in, then you stop the scanner and don't irradiate anyone because the amount of radiation is considerable. And also they are designed so that when you do a body area, you kind of get consistent images and it's easier to assess them. And they are going to include three main things. One is about the patient, so how we prepare and position it, which we already did the other day. We discussed this. They should also have instructions about how and whether you have to use contrast. And then some set of parameters. There's going to be acquisition parameters and reconstructions parameters. Now, why is it so challenging? What's so difficult? Because people get a scan, say, I don't know, you send me protocols and I'll be done with it. It's not that simple. And there are many reasons for this. So first of all, the terminology that each manufacturer uses is different from the other. So you will be seeing these kind of charts that I've prepared. You've got here the manufacturers and how each of them names the different parameters. And it's not only use the name, you can see that with some systems, they do not even use that parameter, or you cannot set up, I don't know, the time of a scanner, you need to change the rotation. I mean, it is quite complex. So each system is different. Within each manufacturer, they have different models, sometimes with totally different workstations. And even with the same model of a scanner, if you've got a 16 slice and a 64 slice, your protocols are still going to be radically different. So that is the first challenge. There is also a lot of personal preferences or different scanners and personal, like not just your preferences, but also your experience. Can you run a certain type of protocol? You may not know how to use, I don't know, fluoro CT or how to do bolus tracking or something like that. So that is also going to mean that some people will use some protocols and others will need adapted them for their level of experience. Even if you had protocols for every body area and for every condition, there's always going to be the dog that is lame on his tarsus and you want to check the nose as well. So you're going to have to start to do all sort of weird combinations, from full bodies to thorax plus abdomen to elbow plus neck plus shoulders and whatever not. So that is also going to mean you're not going to have a protocol ready for every single clinical presentation. And some basic solutions is, first of all, understand your scanner, get applications training. The person who sold you or installed the system for you should be providing you with some training as to how to actually operate the machine itself. And then start with basic protocols, and gradually you will realize when you need to compromise, when simple is good, when you may want to make them more complex and modify them as such. So maybe you will start with a head CT and you will have two, one for small animals, one for large. And maybe gradually you will build a second set and you will have like neuro heads or dental, or the same for abdomen. You will start with a generic abdomen one, but you may realize that you want now to develop or copy one and adapt it to shunts, insulinomas, ureters, whatever it is. Now, looking at the first step, acquisition. So remember, this is happening in your hospital with the patient there, and whatever mistake you do here, it cannot be solved. There may be ways to mitigate it, but obviously, if you want to redo it, you will need to bring the patient in, re-anesthetize, and restart all over. Okay? So preparation of the patient and positioning are critical. Knowing whether you need to administer contrast or not and how to do it, which we will explain on the next webinar. And then there's going to be all sorts of different parameters, which are going to be very specific to your system. And on the last webinar, I will go through some examples of images with issues, and then we can work together to see what it is that we could change if we had to repeat it. Now, you are going to start, as I said, with a preset parameter by clicking your workstation, something which, depending which manufacturer, will have a totally different name. Scan protocol in Hitachi, examination on Siemens. And from there, you are going to select a protocol that is specific to maybe a patient size or a body area or a specific indication. Now, I'm going to go through the things that I reckon most often cause issues and that you need to be aware of. And sometimes it's very simple stuff. All workstations will ask you to confirm that the patient is positioned in one way or the other. You can put the patient differently, but you need to make sure that it matches. So if the patient is supposed to go head first in prone like this, but for whatever reason you want to put it with the feet first, you need to make sure you tell the scanner so. If you do not do that, the left and right sides of the patient on the image are going to be reversed. Okay, so you want to be very, very careful about even the simple basic stuff. Lots of parameters will be by default within that kind of protocol. You may, your workstation may tell you information regarding the post-contrast series or not. And just a very, something to be careful of. If your scanner is coming from a human hospital or the people that set it up are, they work more in the human field, it will come with preset protocols that pretty much they will be rather useless most of the time. And it's not because, they do a poor job in humans. It's because humans do scanners for very specific reasons, unlike us. So they may have very targeted protocols for very specific conditions, and they've got a major goal, and is to achieve, to get an answer to that clinical question with the smallest amount of radiation possible. Okay, they do not put your baby the same way we would put your cat in a CT scanner just because it's not eating. It's just irradiate the whole, patient. Okay, so particularly when you use pediatric protocols, because they're particularly careful with radiation dose, and people think, a baby, a cat about the same size, let's go for pediatric. Okay, so it's definitely no. Now, this pretty straightforward. If you've ever run a scan, you know what this is. Generic term is localizer, which no single manufacturer has chosen to use. They all have different names like topograms, scouts, scanograms, and so on. And these are, when you start the scan, it's going to give you, looks like a radiograph, slightly poor quality. Depending on your system, you may only get one. Maybe you get for the thorax, dorsoventral, or lateral. Other systems will do two, which I particularly like, but it's not necessary. Okay, it's just something you may be used to. Something that gets used, so I'm going to be focusing on where errors happen. The first one is that one of the main purposes, the first thing you do is you look at the anatomy and don't jump into planning the study. Check that the patient is properly positioned. This is just to verify the patient is straight, particularly if you're doing a head, for example. If you see the nose is to one side, go back, reposition, and restart. You've only wasted 30 seconds. It does not take time. So check patient position. You will set where you want to start and where you want to end, and stick to the anatomy. We are looking in this case, for example, are planning for the thorax, for the lungs, starts cranial to the sternum, terminates where the lung fields terminate around the 12th rib. In this case, you can see we've excluded shoulders, we've excluded the abdomen because it's not the part we are focusing here. Then you set the field of view, which I will explain what it is, but you're going to say how much of that patient you want reconstructed. And lastly, you will set the direction of the scan, which again, we explained what it is for in the previous webinar. Is mostly to try to move away from motion, particularly respiratory motion. If you've got a patient in apnea, try to scan first the part that is moving before it starts breathing. So the acquisition pretty much starts there. And I know while your scanner is running, you are already getting some images. So there is some processing happening. And remember, the processing is when we are going to get the data that the scanner is acquiring, and we're going to produce images. And here's where the confusion, there are different processes to acquisition, but yes, they do happen simultaneously. And in fact, when you look at how manufacturers call it, it's pretty obvious. So if you plan those reconstructions before you fire the scanner, they will have one name, so it could be prospective recon, recon or additional recons, recon job, prospective. While if you plan them after, they tend to be retrospective or post or offline or something like that. So technically, if you mess up these ones while you are running the scan, it's okay because you can go back and do exactly the same thing as many times as you want, okay? So you can just repeat it and get as many series if you missed something, or if you are curious about a thicker slices, I want to play with different filters and whatnot. Now, these are the parameters I wanted to discuss, which are the main ones that you need to decide for every single case. One is the filters or kernels that we use, which determine sharpness and smoothness, or how soft the image is. Slice thickness, pretty much self-explanatory. The distance between slices sometimes creates confusion and is something people overlook, because if you don't know how to find that information or how to look at it, you can miss it altogether that you've used the wrong parameters. And lastly, the display field of view. One of the parameters that is most often overlooked, particularly when it comes to things like orthopedics, spines, is very often badly chosen. You can see here pretty much everybody agreed with the name, except Siemens had to go a bit rogue and just call it FOB. All right, so slice thickness, pretty straightforward. How much tissue is going to be sampled to produce that image? Even though it's simple, to some extent, thickness is a little bit a strange parameter because it can be in part considered an acquisition parameter. And the reason for that is because your scanner is also going to have collimation that is going to make the slice that is scanning every lap thicker or thinner to match kind of the rows of detectors that are on the other side. So as an example, if we take this one, this for example is the screenshots from different manufacturers, but they all look pretty much the same. You will be given a choice of how many detectors you may want to use, and this is down to the geometry of the detectors themselves and how the data is passed through the computer. But for example, here, if you wanted to do 5mm slices, you can see in this case, you can either use 128 detectors of 0.6mm, or you can use 32 detectors that are 1.2mm. And it's because the system is combining those 0.6mm in a certain way. And technically, you are going to be achieving the same image, you could think, because it's 5mm, but it is really not the case. Normally, there is going to be a significant difference between both in things such as acquisition time or even how much noise you get and so on, because the way the detectors work. Now, it's not very important. Play with both. As soon as you change from one to the other, you will see the impact on, for example, scan time. But when it comes in, something you need to keep in your mind is that if, for example, you are considering you may need super high spatial resolution because it's you're doing a head, you may want to reconstruct at 0.6. You have to make sure you select this one. If you select this other one, you will not be able to reconstruct below 1.5mm. Okay, so some acquisition parameters will limit your ability to reconstruct. Now, reconstruction parameters that people tend to overlook is what we call the slice overlap, or the distance between the images. Each system, again, have a different name for it, and I'm going to explain what it is. This is a massively thick slice that I made for this example. So we have sampled all that tissue to produce a 2D image, and that's a 2mm thick slice. And we have selected a parameter that is the distance, the interval, increment, whatever it's called, of 2mm. That means that the next slide and the next one and the next one are going to be kind of touching each other. And it makes a lot of sense to say, okay, well, if you do this, you've got the entire volume of the patient. So that's probably the most efficient way to do it. Now, these slices, they do not overlap, and they are 2D images, and there is something we call a slice profile. So for some reason, this is going to result in images in the 2D are going to look great, but when it comes to doing multiplanar reconstructions or 3Ds, it's going to be terrible. The other thing, like sometimes we do on MRI, we may do, for example, 2 millimeter slices every 2.5, and that means there are little gaps where we have patient that is actually missing in our images. And this happens very often when people are not aware of these parameters. You change the slice thickness, you do not change the interval, and then this happens. And normally what we want, we do one slice, say 2 millimeters, but the distance is going to be 1.5 millimeters. So it's the distance from the beginning of the slice. It means the next slide is going to kind of overlap quite a bit with the previous one. And it means we get a lot of redundant data, which is really good to do 3D recon. So you have to make sure that your slices overlap a little bit. And this is how much it impacts. So these are exactly the same slice thickness. They are pretty much identical images. I think this one is one slice above than the others. And we have changed the distance from one image to the other. So in this case, half of the patient is missing. You have 0.6 millimeter slices every 1.2. Here they are contiguous, they are touching each other. And here they are actually overlapping a little bit, like about a 20%, a bit more. And look at the difference when you do the MPRs. If you look at the carpal bones here, you cannot see joint spaces. Looks like these bones are fused. You could have a fracture, something you wouldn't know. Look on the slices that are contiguous, you start to see that joint space a little bit, and just compare how beautiful image you get if the slices overlap. Okay, the same for the teeth. In transverse, if you only look in transverse, the images on the left and the right are identical. They are the same images. Okay, but it's when you come to do MPRs where you can barely identify a tooth there. So long story short, you need it for pretty much all series, and ideally you want to overlap at least a 15, 20%, and definitely way under 50%. If you go above that, your MPRs are going to look amazing, but you're also going to end with 20,000 images, which are very difficult to handle. So I do slices of 1.25. Distance, I normally would do a 1 millimeter, 0.8, so something like that. 0.6 millimeters, you can guess, it's going to go, normally I would even 0.5, but at least like 0.4, something like that. And if you have 3 millimeter slices, I don't know, something like a couple of millimeters will generally work great, okay? Now, this is probably the most important part, is the filters, and they confuse a lot of people. Basically, this is going to determine how smooth or sharp your image is. How they are called, again, is a little bit different. Most of the time, they used to be called filters. Other people call them reconstructions, kernels as well. So filter/kernel or recon type on GE kind of covers that. And it is not set, it's not like a computer. Well, GE tends to have fewer, but it's actually like a spectrum you should see. In one end, we've got super smooth images, too blurry to be looked at. In the other end, we've got super sharp images, so sharp that they are too noisy. The blurrier you want the margins, you go to the left. The other end is going to be sharper, accentuated margins. So the farther you go towards the left, the ones towards this side kind of the spectrum are going to be images that have poor spatial resolution, but they do not have noise. It means they are really good for soft tissue. So you are going to at least need one of those. There's soft tissues in every part of the body. It doesn't matter if it's an elbow or a nose, you always do one of these. And then it is the opposite for sharper ones. They are terrible for soft tissue, but there is always bone or gas or something like that in a structure. So even if it's an abdomen, you still do a bone series, because if you've got a small ureter stone or a small gas bubble free in the abdomen because of peritonitis, you're going to miss it. Okay, so we always need one of each. How you identify them is a total nightmare, because here the manufacturers have really gone wrong. Some of them use a numerical value, and it tends to be pretty straightforward. So the tens, the first digit, it tells you how sharp it is. So very low numbers are very smooth images. So I rarely ever would use something like a B10. And it goes up to 90 in most systems, and that is going to be way too sharp. So you need to find something kind of at the bottom of them, something above. Now, you may have other characters and quite a few letters. Do not worry much about those. You can just play with it. So you may have mostly the type of filter, whether it's an iterative filter or a back projection or whatever. Okay. And then the second digit, yeah, just determines some fine tuning of the filter for specific purposes. But long story short, for soft tissues, you want 20 to 40 roughly. For bone, I would say generally, or lung, 60 to 80, something like that. For others, like GE, for example, is words. So you make sure you understand the meaning of the words, because with GE, this is a classic one where I don't want to do anything fancy. I just want to do a standard image. So they select standard, thinking that this is standard for whatever standard it is. Standard, for example, is a soft filter. So they go in this order: soft, standard, detail, bone plus, edge, and lung. So for example, for lung, personally, I'm very happy with bone plus or edge. You don't necessarily need to follow that, but the bottom ones are sharp, top ones are a bit softer, okay? And remember, the name of the series has nothing to do with the filter. Technically, if your scanner is properly configured, yes, you will have, like here, we've got soft T is the name of this particular series. This scanner is given it, and this is the kernel. But the name is something that you type and you change, okay? So very often people will just change the window, they'll repeat the exact same series with the exact same kernel, and then send them and say, I know it's a soft tissue and a bone. They know it's the exact same image. Okay, what we need to make sure is different is the kernel. And in the last lecture, we will go through cases and I will show you how to, without diving into the metadata of the image, just look at the image and get a pretty good idea of what type of filter that is. Now, the display field of view, one that is so often forgotten, misused, and it impacts image quality more than slice thickness even, okay? You need to decide which part of everything that goes into the scanner you want to image and reconstruct, okay? Basically, the scanner scans everything as it goes in, and then you need to decide which parts you want to see on that image. A pretty standard name, FOB, DFOB. There is also a scan field of view, particularly, for example, in GE is different, so we are looking at DFOB if you have two of them, okay? This is the reconstruction parameter, not the other one. An example with photographs, I think this will hopefully help you understand the idea if you don't have the concept clear. Taking a photo of my garden last year, we've got a lupinus there, a flower. This is a 4 megapixel image. That means we've got like a matrix of like 2,000 columns and 2,000 rows of tiny little squares, each one with a color. So it's quite a high resolution image, but if I want to see in detail that flower and I start to zoom in, I am just selecting a small part of those pixels. So maybe I'm going to end with an image that say, I don't know, it's 100 by 100. So I start to see the little pixels and the image looks pretty terrible. I'm sure you've taken a photo with your phone that looks great until you zoom in and you say, oh, that's actually really bad. If you want to see that photo, you walk, sorry, that flower, you walk up to it, get closer to it, and repeat the photograph. And now you've got the 4 million pixels, so 2000 by 2000, and you can see all of the little details. And this is exactly the same for CT. So if you need high spatial resolution, like for example, for these elbows, and you have reconstructed all of this, so you can see there is like a black square that's outside of the scanner, and this scanner has made a field of view that is round, and I can measure it, and it's 38 centimeters. And what we are looking is at this. Generally, the matrix that we have on an image is just about a megapixel. It's just 500 by 500. It's quite low resolution. You can, some scanners go to 1,000 and so on as well, but it doesn't matter. It is a limited number of pixels. So if you go into that and you zoom into it, you say, okay, let's make that big and look at this coronoid. It's absolutely terrible. I don't know if the joint space is maybe narrowed, or is that just that pixel in that line? Is that a fracture, a fissure, a trabecular bone? I don't know. Basically, you want to get images like this. So if you change the window, the margins of the image are pretty close to the anatomy that you want. So if you zoom on this one, well, it's actually the same elbow reconstruct. It's not that one, but you're going to see the amazing difference. Okay, so there's absolutely no point in doing 0.5 millimeter slices, the thinnest your scanner has, and then reconstruct 40 centimeters, because your pixels in the direction of the 2D image, okay, are going to be tiny, but in the other direction are going to be huge, and in the other direction are going to be tiny. So you do not have isovolumetric voxels. So it is very important. You want high resolution, and you do thin slices, then your field of view must be small. And for things like orthopedics, as small as you can get, generally well below 15 centimeters. Otherwise, it's a waste of time just doing reconstruction. You just may as well crack on and take some radiographs. And it is, you can say, I don't know if my frustration transpires, but it's just so common that they do properly position, really nice everything, and then they don't they reconstruct the whole, the whole two elbows with the neck. And then, yeah, you just lose all the resolution. And look what those two images look like when you do the sagittal. All of the information is going to be gone. You cannot see the joint spaces and so on. Now, 31 minutes. I'm going to take, no, I think I'm going to leave this one. I'm just going to show you very quickly. The next day, what we're going to be doing is going through some body areas, and I'm going to explain you exactly how to run the acquisition, which exact filters you are going to need, at least as a minimum, and how you review them. Okay, and we will do this based on images that we can look at together, and I can show you how to determine or how to kind of get a subjective idea of how good your own studies are. I think that would be the main purpose, is that the next time you run a scan or you open a scan that someone has sent you, the very, very first step you should do is look at it critically and try to decide if it is of good quality. If you cannot do that, then you cannot really trust your diagnosis or anybody else's diagnosis, okay? And if it is you that is running it, then what you're going to learn is what went wrong, and then potentially you're going to be able to optimize those protocols for future patients. We'll go through that on the next talk. And just as a quick reminder of what's going to be coming on the next two webinars. So webinar 3 is going to be, it's going to be a lot of detail. Andrew Holloway's extremely experienced about this. He loves all of sort of contrast uses. And I know this is the part where most people really struggle with. So it's going to be everything contrast related on that one. And then in the last one, yeah, we will do some basics of viewing technique. How do you open a CT study? How do you look at it? How do you decide if you've got everything you need or not? And help you set a paradigm, a set of steps fixed that every time you open a study you do to confirm how good the images are. I apologize, I think I overran a few minutes. I don't know if anyone has posted any questions or not. Jemima?
Yes, we've got a couple. I'll start asking them, but if anyone else has any, please feel free to click on the Q&A box at the bottom and add to them. They'll come through. So the first question, Manuel, we've had is, I'm new to scanning and I haven't done very many. And so I think I often set the start and end points for a body area too far apart because I'm worried I'm going to miss something.
Yeah.
Am I doing the wrong thing?
Okay, well, yeah, okay, let's look at it. So first thing is that that could potentially make you not be sure about where to start and where to finish is the certitude you have as a clinician as to which body areas you need. So that's the first one. So sometimes you may not be able to pinpoint the condition. Your dog is coughing, you want to have, for example, the entire neck, and then you may extend your scan. So there's a clinical justification. Of course, you are not doing the wrong thing in any way. You do need to explore all the body areas of concern. However, if you overscan things, you start to enter the risk that you are maybe going to start finding things that potentially sometimes, you may not necessarily want to know they are there. Basically, you are going to start to complicate your investigation. And this is a typical example. If you have an old boxer, I always put as an example, if you get a 14-year-old boxer, if such a thing exists, which sometimes they do, and you do a full body scan trying to find something, trust me, you are going to find a lot of things. And it can actually complicate the exam and your clinical progress on that particular case. There are also other things as radiologists we do not like. We like to stick to the pure anatomy because it takes longer the more anatomy we have. So if it is something that it is not clinically necessary for you to have on that image, it's better to stop it. You irradiate less the patient, you use less the system, you end with a smaller study. So there's lots of advantages to trying to stick to one body area. We do have a set of protocols that I don't know if they are available on the web. You may know better than me, Jemima, but I'm sure they can ask for them. We share them for free. They are very basic, but they do cover these kind of things, where you start and where you end. So I don't know, for example, for a head, generally we do a generic kind of head CT. We do not do like brain, nose, we do the whole thing. And we like to include just a little bit of the neck to make sure the lymph nodes are there. So we kind of give you guidelines as to where you should start and where you should stop. Okay, but yes, the thorax, for example, does not finish in the pelvis and things like that we regularly see. Yeah. So I don't think that answers that.
I think so. If that hasn't, drop us another note. The next one we've had is also from someone quite new to scanning, and it's where can I find guidance on the best slice thickness and overlap to use by body area?
Okay, so again, those you can get them in our protocols. Our protocols are rather basic in purpose, not in a bad way. As we've simplified them to make sure that they can, everybody of all levels of experience can achieve them. Like you can follow all of the steps and achieve satisfactory images. And they are quite generic. Like, for example, we're going to have a head one, which I believe, well, it will, depending on the size, it will tell you. You go on it and then you look, okay, small dog or cat or rabbit heads, we would use certain slice thicknesses. If it's a bigger dog, we tend to use kind of thicker ones. But you can potentially decide, well, it's for teeth, then I will make them thinner. So it's always a little bit of a choice. But the protocols that we have will give you the basic indication to get you started and make sure that you do not do something that is totally not suitable for making a diagnosis. That you don't end making too thick slices, or you don't do a brain with, for example, 0.6 millimeter slices and things like that, because we are not going to see anything. Yeah,
Okay.
so I think, yeah, those documents should give you a start on that.
Yeah, and I think to that point, Manuel, we do have the ability for people to contact us and ask questions as well, right? So if
Yeah.
they've got area they've never scanned before, if you've got an area you've never scanned before and you need advice on how to acquire the best images, you can contact our team and we'll be able to help you in that instance.
Yeah, absolutely. Yeah, in particular, as I said, it can be very complex because even if you've got really good protocols, there's always going to be the odd dog where you want to do, I don't know, the thorax and the spine. And the thorax, we do it on the sternum, the spine on its back. So which one do I do first? Well, do I do it? If you have specific cases you need help with, you can contact us, and then our radiologist will get back to you with some advice. Yeah.
Great. The next
Radiographer, I was going to say, we do also have radiographers in the team who are the true experts on image acquisition and processing, really.
Yeah, and they'll love that you've said that as well. The next one is, how do you approach requests for multiple ROIs, e.g. head and thorax?
All right, so that I will try to give you the basics on the next one as well. It is very common that you are not interested in one single body area. Lots of clinical presentations will require you to scan at least 2 or 3. As I said, the first thing is to accept that you are going to have to compromise generally, and you may have to decide which part of the scanner you want to compromise most. So why am I doing the head and why am I doing the thorax? Because I don't know if it's something very specific on the head. I'm looking at neuro. I really like really high detail soft tissues. Potentially you may have to just do the head, like do a proper head study optimized for brain, and then do the thorax completely apart. So you can still scout everything in one go and then set them as separate acquisitions. And that is generally what works best. If your body areas, for example, are close together and the protocols are fairly similar, like for example, a thorax and an abdomen, I would generally just scan it in one go. Just assume it's just one big thorax or one big abdomen, and you can fine tune it a little bit to certain things. If you are more concerned about the lungs, you may do some type of acquisition versus the other. But yeah, as soon as it comes to multiple body areas, I suspect you may have these questions. I don't know if Andrew will be able to answer them all, because where it is very difficult if you acquire, for example, a head and a thorax completely apart, so you just do the head, stop the scanner, start it, and do the thorax. Where the challenges really start is what if you need contrast in both body areas. Because if we say, I don't know, you need to start this acquisition 45 seconds after you deliver, you start delivering the bolus, well, you cannot be in 2 places at the same time, let's put it that way. So you are going to have to decide, okay, which one is more important? So I will compromise more in the other part. Okay, so it's a little bit of a compromise. It's a life, like you say, it's a real balance, and it's definitely not easy. I think the combination of body areas is the hardest part. And that's why if you can work in a perfect world where clinical indications are very clear, your clinical exams are always sharp, precise into one single region, is great. But I know the clinical environment it doesn't work that way pretty much ever. Yeah.
I think there's another one that follows on from this, which is to do with front leg position for thorax and head thorax.
Yeah.
So someone said they had a coughing dog recently with issues, and they were scanning head and thorax and got quite confused about where the front legs should be.
Okay. Yeah. Well, they have to be somewhere, don't they? Again, it's a compromise, and this is where a lot of personal preferences will come into play. I find it that they do not affect much the thorax because you already have the spine, you've got a lot of things, so I tend to put them along the body. You can put them parallel to the head. Some people try to very kindly, because if you include the whole front limbs, then we need to look at those as well, and it adds significantly to the review time. So people try to put them in weird ways, like to the side, so they are at least outside of the image. Sometimes that actually makes more artifacts. I appreciate the effort, but sometimes the fact that they are not aligned with kind of the table, but parallel to the scanning plane, they create more artifacts. Personally, I would not be able to give you a choice. I think most people would put them forward, mostly because of the position of the patient seems a little bit more anatomical and comfortable, and also you have easier access to the catheters, which tend to be in the front legs. Okay, but if you are doing head, neck, thorax, for example, generally the front limbs will be included in the image. If you want to exclude them, another thing you can do is just put them forward, like in a sphinx position, and then you reconstruct the head, which should be in a smaller field of view, and then a larger one for the thorax. And then you've got the perfect images optimized, and then the elbows, carpus, and so on are no longer included.
Amazing. And then there was one question about scanning both elbows. Can they be done at the same time, where you've talked smaller?
Yeah. So it is it's a very good question. I actually, well, I could show you. I was going to start talking about elbows. I'm very passionate about elbows. I like reporting them. Yeah, I enjoy elbow imaging, orthopedic imaging in general. One of the rules that I said is when you are scanning something, you want ideally only that body area included in the scan and centered. If you include both elbows, you are kind of breaking those two rules because you cannot center both, is one or the other, and then you don't have one elbow, but you have both. However, having said that, I absolutely always would scan both at the same time because the presence of one is not enough to really affect the other one. It also means you are going to save time, you are going to save radiation. So it's a win-win. It does not really impact the image. And also, if you keep them close together, I'm sometimes even that lazy. You put them together, then you can reconstruct them in the same field of view. If you do it with a little bit the elbows farther apart, then you reconstruct them separate. That's very important. But yeah, you can absolutely scan both at the same time. I think it's pretty much a standard. The other option is just do one, retroflex the neck, and then do the other. Okay. I'll make sure that I include a little bit of orthopedic protocols on the next webinar, and we go through probably what is the hardest ones to get right, which is the front limbs, is probably the most complicated one.
Perfect. I think that's it, Manuel. That's
Okay,
it
cool.
from questions. Would you mind just going on to the next slide, I think?
Yes.
You mentioned earlier that this is webinar 2 of 8, and this is how people, anyone viewing, can access the other webinars. If you scan this QR code, you'll get taken to a page which will list all of the webinars, and you can sign up for them there. As Manuel said, the next 2 are theory-based, one on contrast, and then the last one on viewing and reconstructions. And then we have 4 on case examples. So we've got 2 amazing radiologists then giving really good examples of the use of CT in specific patients. And as I mentioned earlier, if you've got any questions about how VET.CT can support you in your practice, if you'd just like to find out more, if you'd like to see examples of our reports, or find out more about how our specialist team can also support you, please feel free to email sales@vetct.com. It won't tie you into anything and it won't obligate you to anything, but you can find out more very easily and very quickly. Thank you, Manuel. Thanks for a great talk.
Much. Bye.